Start the recording. That would be helpful. So we strive to achieve this goal by supporting BIPOC-led community-based organizations to deliver on and expand existing work by providing resources and connecting CBOs with systems and services and addressing systemic racism by funding critical research and BIPOC-led organizations, particularly those who would typically not receive funding. One of NJBEFA's guiding principles that complements its approaches to change, mission, and vision include uplifting collaboration, learning and co-design, learning sessions with or for the community, such as the critical community building and deepening understanding. These principles mimic and enhance the guidelines of participatory grant making and trust-based philanthropy, which we use as our guiding frameworks. Our principles and the frameworks of participatory grant making and trust-based philanthropy has guided us towards stewarding several areas of grant making. One is a research project to landscape the field of community-based organizations in New Jersey, in which we use that data to then support community-based organizations with technical assistance. That technical assistance will be guided by a TA delivery service for these community-based organizations. We also have a community advisory fund that is stewarded by a community advisory committee that in 2022 has dispersed over $170,000 in grants across 18 grantees, 7 for rapid response, to respond to the diaper and formula shortage in New Jersey, and 11 postpartum equity support grantees. And this community advisory committee is a group of 5 to 7 people that guides the approach towards the grant distribution. And then our final one that we have done or that we are in process of doing is the executive on loan, which is sponsoring an individual to report to the Office of the Governor that is responsible for implementation of the Nurture New Jersey strategic plan. So those are some of the areas of grant making that we have done so far. So to get into the introduction of our presenters today, I'm happy to introduce our first speaker, who is Dr. Nastassia Harris, the Executive Director of the Perinatal Health Equity Initiative. Now, Dr. Harris is a registered nurse, an international board certified lactation consultant, and the founder of the Perinatal Health Equity Initiative, a nonprofit advocacy and support organization dedicated to eliminating racial disparities in Black and maternal health. Our second speaker will be Jayvonne Santos, and Jayvonne is the CEO and co-founder of MyLua Health. Jayvonne Santos is a Cornell MBA graduate and seasoned serial entrepreneur with 7+ years of strategy and operations experience. Currently, she is the CEO and founder of MyLua Health, an intelligent maternal care coordination service that seeks to advance health equity and mitigate maternal morbidity. Our final speaker will be Kimberly Seals-Allers. Kimberly Seals-Allers is an award-winning journalist, 5-time author, international speaker, strategist, and advocate for maternal and infant health. A former senior editor at Essence and writer at Fortune magazine.
Yes.
Because I wouldn't know.
Yeah.
I know one thing.
Yeah.
And then she's
Someone is off mute, if you don't mind
and
muting.
the rest I hear is rumor mill.
Right.
Okay, I'll mute it for you. So she's the founder of Earth, a new Yelp-like app for Black and Brown parents to address bias and racism in maternity and infant care. Kimberly also created Birthright, a podcast about joy and healing in Black birth that centers on positive Black birth stories as a tool in the fight for birth justice. It reverses the narrative of negative statistics common in mainstream media coverage of Black maternal health. So we are very excited to have these speakers here today, but I also want to note that if you have a question during the conversation, please put it in the chat and it'll be addressed at the end of each presentation, at the end of all of the presentations, I should say. The other thing is that I just want to see what some people's thoughts were about data, if anyone placed anything here anyway. Didn't see anything, but that's okay. Just thinking about what you think about when you think about data, okay? So data, someone says important information, community-based solutions equal advocates. Community-based solutions makes me think of gathering inputs and ideas from those who live there, a truly local approach to improvement. Data is interesting, and community-based solutions equals collaboration. Community solution equals a solution that grows from the community itself. What else? Data equals information, and community-based solution equals indigenous strength. These are great responses. Data equals numbers and narratives that can inform public health program strategies and solutions. Wonderful. Someone says, I think about the importance of data inclusion in collection, transparency, and storytelling, as well as the importance of interdisciplinary collaboration in addressing public health needs for the perinatal health population and health programming. Raquel says, when I think of data, I think of numbers that tell us a story. And Marshall says, data tells a part of the story and provides insight. Thank you all for that insight. Data makes me think of demographics of subjects, information, and proof of initiatives. Wonderful. So thank you all for your input. I am going to stop my share so that Nastassia Harris can jump in and start her presentation.
You're on mute.
Yeah, Nastassia, I'm not able to hear you.
Yes, I was trying to figure out where to unmute since I started sharing. Good afternoon. It's afternoon, right? Yeah. Afternoon, everyone. I am Dr. Nastassia Harris. I am the founder and executive director of the Perinatal Health Equity Initiative. I also serve as an assistant professor of nursing at Montclair State University. And I'm going to talk a little bit about dismantling racism in research, using the lens that we use to do our work as an organization, and the work that I do as a nurse scientist, and just give some frameworks to work from if you are looking to engage in research in communities of color. So I want to start by just telling you all a little bit about who we are. We are a 501c3 nonprofit organization established in 2018 with a specific mission of eliminating inequities in Black infant and maternal health. We are designed in the service of Black mamas across social and economic backgrounds. And that is important because when people hear nonprofit, they typically think low income, vulnerable communities. And we do a lot of that work, but want to be clear that the income is not the defining factor in where these inequities exist. It is racism. And so that affects Black women, regardless of where you are in your socioeconomic status. So just want to make that statement clear. As I use the terminology Black Mama, we are a member of the Black Mamas Matter Alliance and have adopted their definition of what a Black Mama is. And I'm not going to read it because it's a long slide, but it basically is a all-inclusive term that includes any birthing person. All right, so some acknowledgements I want to address as we move into this space. First and foremost, Black women are the authorities on their own lives, period. What that statement basically means is that if you do not have that lived experience, you are not from that background, you are not able to come in and place kind of your input on that thought process. There's these concepts of cultural humility, which I will talk about in a bit, but just wanted to be clear that coming in as a research perspective, our viewpoint is collaborative, not a hierarchy in the research where the researcher is the lead and the participants are, the subject studies. We are working in collaboration with those who we engage in research with. Also want to acknowledge this could be an entire presentation on its own, but the historical trauma that has broken trust across generations. Some examples you might be familiar with are Lucy and Anarcha, who were victims of Marion Sims and his work, the Tuskegee experiments, Henrietta Lacks. So there is a history of abuse of Black bodies, and so that creates some resistance in participation in research. These studies were literally the foundation of medical racism and designed to dehumanize Black people. Who is doing the research matters significantly. It is not to say that non-Black people cannot engage in this work, but there is a different lens and lived experience that comes with doing researcher as a Black woman. And so we really should be looking at how there's potential for disruptions in cultural rigor, integrity, and validity of the results of the study when they're not done by Black people. Looking at culturally responsive methods. This image that you see here, if you're familiar with research, have probably seen, which is really the hierarchy of what validates what research is actually important or not. And you can see if you were, a lot of my work is really centered in the qualitative space. You can see that that is very low on the list of valid methods of research. And so decolonizing that process means that we are looking at research methods that are best informed by the community we are tending to serve. And that may not be the typical gold standard of a clinical research trial with our community. We're looking more at stories and lived experiences. Important to that factor is to cite and fund Black scholars. More often than not, the research that is being done by Black people on this subject is not being cited or recognized or being pulled from. And Black researchers are also less likely to receive funding to do their work, so something to consider. But our framework is that storytelling is a culturally responsive method to engage in the work in our community that we serve. This is one of the frameworks that we use. This is actually the Black Mamas Matter Alliance conceptual framework for doing research in the Black community. It centers around Black feminism, birth justice, reproductive justice, research justice, womanism, and human rights. And basically all of these things are designed to center the Black lived experience as the expert in their own lives and the work that they do. Black feminist thought centers the lived experiences of Black women and unapologetically centers Black voices. Womanism embraces the cultural nuances and spirituality of Black women. And research justice is really just to decolonize current research methods and acknowledge Black women as the experts and knowledge keepers. This issue is an intersectionality issue. It crosses gender, race, and class when we look at our demographics for the birthing people that are impacted. So keeping in mind that those things are not separate, they are all part of the same work. And then community-based participatory research is how we engage in the community work, which I will post on share shortly here. So if you're not familiar with community-based participatory research, it is a collaborative method between the community and the researcher. As I said, not using a hierarchy scale, but really looking at collaboration with the researcher and the people who we're doing the research with as collaborators in that process, really leaning on them to help to develop the questions that we're going to ask, how we're going to ask those questions, and how we're going to interpret the data that's received. Again, positioning Black birthing people as the authorities on themselves. If you are engaged in this work, you really should be looking to engage with Black-led organizations who have expertise in this space to help guide the evidence that is going to be generated. The community is involved at every aspect of the study, as I mentioned, from developing the questions, actually conducting the research, interpretation of the data, and dissemination, which is super important because oftentimes data collection from the Black community is extracted and it's exploited and it's not given back to the community. And so the dissemination piece is a huge accountability component of doing the community-based participatory research. Assets over deficits. This basically means that we are not looking at Black people from a lens of disparity, but we are looking at them from what what are the assets that Black women possess that they are bringing to the table that can help amplify and show improvement from the inequities that we are looking at. Everything about Black birth and Black women is not negative, and we can't continue to view Black people in that light. 3 tenets which were developed by Dr. Fleda Jackson in this space include cultural sensitivity. And this basically has to do with an in-depth understanding that the researcher has of the structural contributors to Black maternal health. So the researcher essentially must do their homework first and really requires the understanding of the intersection of race, gender, and class to be immersed. In the study of Black women, the objective is to learn how race, gender, poverty, and oppression influence outcomes, which must be free of assumptions. Reciprocity basically calls for equality of the researcher and the participants as they engage and work together through collaboration, not as subjects. Again, amplifying the authority of Black women, and the project should be mutually beneficial for both the researcher and the community of service. And then accountability speaks more to the researcher and their accountability to the participants as it pertains to the rights of the participants and the dissemination of the results. And by dissemination, I don't simply mean publication, but how that data is returned to the collaborators who help to collect it. And those principles are aimed at disrupting the typical exploitative experimental history of Black people and research. So as you're engaging in this work, some things I encourage people to think about is, does it need to be you that's doing this work? Or are your efforts best served somewhere else? What are your motives for wanting to engage? Have you done your homework? Otherwise, we end up with results that are misinformed and misinterpreted and often presented from a lens of disparity. Black researchers, non-Black researchers should be following our lead in reshaping this work and seeking partnership. And that is the essence of cultural humility, as you can never fully understand the lived experience of a Black woman as a non-Black person, but you can continue to learn and engage on that continuum. This is a quote from the Black Mamas Matter guide that was on doing research in Black communities from INAZ. And it basically states Black women researchers bring a combination of lived experiences and research training together to bring a desire for love, justice, and applied research principles to the field of maternal health. The research I conduct with love and scientific integrity, which expands the potential for the real meaningful impact to advance Black mamas' maternal health. And that quote resonated with me because that is really the essence of why I do this research. It is not for tenure, it is not for publicity, it is not for saviorism. It is out of genuine love and compassion for Black women in our community and wanting to have a guiding hand in changing our current narrative to ultimately create joyful experiences across the perinatal continuum for Black women. How we tell the story matters. Will I die? Avoiding fear and uplifting joy. Basically, if we continue to paint a picture that Black birth is dangerous and you're going to die, that's the perception that the community has. And many women are in fact afraid to become pregnant because they don't want to die as a result of that pregnancy. So we need to make sure there's balance in how we are sharing and telling the story. Steer clear of trauma porn. And this is basically the need, which I see happen a lot of. We are tapping in on Black women to share these horrible, horrific stories of their birth experiences. And then they're left to sit with that information and relive that experience. So keep in mind that you are often re-traumatizing people by having them retell a traumatic experience. And what support are you providing for that storyteller? Are you connecting them with mental health resources to help them deconstruct what happened to them? It shouldn't just be a platform for someone to share a horrible outcome, but also make sure that story is also combined with amplifying joy. There are beautiful Black birth experiences that are happening, and people need to see that. They need to hear that because the only image people are seeing now is death and dying, and that doesn't facilitate a healthy, happy pregnancy. Black women already, because of our history in interacting with the healthcare system, already have high anxiety when we're interacting with the healthcare system as it is. And so we need to be careful in the narrative that we are sharing. So quickly, I want to share how we use data. This is a picture of us at our community baby shower that we held. We use our data to guide how we interact with the community. Data and evidence-based practice informs every single thing that we do. Nothing for us without us. And I say that as a Black woman. Our work is centered in the community of East Orange. I am not from East Orange. I'm not even from New Jersey. And so while I am a Black woman in that community, it is not my community. And so I need to seek guidance and information from the members of that community in order to shape what we are doing there. So nothing for us without us. We use it for program development, for fundraising, so people can really understand what's happening in the community. For advocacy, we've had to make several phone calls based on data that we've received from families to providers and hospitals for the inadequate care that our patients are receiving, to advocate for policy changes and responding to the needs of the community. And then lastly, I'll just share a couple of our community projects. Our first is a community needs assessment, which you are doing in East Orange. This is the maternal child health focused needs assessment. Again, because I am not from East Orange, we are wanting to do an in-depth understanding of our actual community. East Orange is one of the 7 or 8 communities in New Jersey that have very high Black infant mortality rates, and our current work is designed to take East Orange off the list. We want to move one city at a time. And so in order to do that, we need to understand the inner workings of our city. And so the research that we obtain from this needs assessment is going to inform the programming that we build moving forward. We are also engaged in a Black women's preeclampsia study, which is also a qualitative study, focuses on understanding the lived experience of Black women who have been diagnosed with preeclampsia, which is currently missing from the literature. And then lastly is a Black breastfeeding landscape, which looks at all 21 counties and how breastfeeding is happening in those communities for Black women. And that is a report that is actually funded by the Burke Foundation, which is going to be used to seek funding, to make policy recommendations, and for programming. And so that is the way in which we use data within our organization, in addition to evidence-based protocols when it comes to the management of clinical care. And this is all of our contact information. We invite you to follow us on social media, sign up for our newsletter. I will plug that we are having a conference, a birth equity conference in May. It's May 19th through the 20th. Tickets will be on sale tomorrow. So I hope that you continue to engage with us in this work. Thank you.
Thank you so much, Dr. Harris, for that lovely presentation and learning more about how we can see through the lens of the community to create community solutions. And please feel free to put the link for the conference in the chat so that people can take a look at that. Our next speaker and presenter is NJBEFA Santos. And NJBEFA, I will turn it over to you.
Thank you. I appreciate it. I'm going to share my screen. And Dr. Harris, that was amazing. So thank you for presenting. So my name is NJBEFA Santos. I am the CEO and co-founder of MyLua Health. Very, very happy to be here and just share a little bit about what MyLua Health is, how data plays into our story as a means of amplifying voices ultimately. MyLua Health derives from my sister's story, so I'm going to have to start with that. So on the right-hand side, that's Julia Santos, and it was her birthing experience that gave birth to MyLua. I'm one of 8. I'm the glorified doula in my family. I'm definitely not trained as a doula, but I've seen 5 births. And during her pregnancy, it was amazing. But during her birthing experience, she was denied medical intervention. And that leaves a lasting effect as it pertains to emotional and mental challenges post. So it's just grappling with that. She came to me and was like, hey, we have to solve for this issue. How do we amplify voices? How do we utilize data? And this is the solution we came up with. And we are an AI-powered early risk detection service for the pregnancy and postpartum period. And as we all know, that the maternal care system is obviously broken, and we're facing a maternal care crisis in the US. We're the only developed nation with a rising maternal mortality rate. And this is kind of where our mission derives from. So we're advancing health equity and mitigating maternal morbidity amongst all birthing people by amplifying lived experiences through data. We know that 80% of deaths, according to the CDC, are preventable maternal deaths, and 25% of those deaths are directly related to mental health issues. And this is why MyLua is starting with addressing mental health issues first. So in general, a large contributor to maternal care complications is missed and delayed diagnosis. And this is because of poor screening practices and lack of data collection. So there are 1 million moms annually that are low risk pregnancies that experience unexpected complications, and they escalate to them being in a medium and high risk state. And because of this, they're not identified timely, and conditions also often begin to exacerbate in symptoms as well. The healthcare system is too overburdened to actually deal with this issue in a timely manner, and it's making it difficult for providers to identify when needs are changing. Also, miss and delayed diagnosis result in substantial avoidable costs. So there's around $14 billion just due to miss and delayed diagnosis for depression alone. Social drivers of health are difficult to collect across the board, but they also contribute to 70% of all care outcomes. So some of these social drivers of health might be lack of resources, might be food, housing, insecurity, or just lack of social support. And during our customer discovery, we were asking birthing people if they're having these important conversations with their providers about challenges of mental health or transportation, and it was a resounding no across the board. And a lot of this stemmed from fear of child protective services being called, or just a lack of a response because there might not be resources for them. But when we asked, would they actually like to be having these conversations, the answers were yes. And that was if a solution was provided to them. So we began to kind of build out this solution, and we're considering solutions for screening, data collection, access to resources. But there are two very important factors when we begin to think about these types of solutions. And we know that because of the foundation from which maternal care stems from, Dr. Harris said it earlier, it's really about trust in the community. And because of the experimentation and exploitation of enslaved persons without their consent, this becomes a huge barrier to entry as it pertains to gaining trust. But in order to get the appropriate data to intervene in a timely manner, we need to reduce this barrier and begin to build this trust. The second factor is those really uncomfortable conversations that lead to unearthing of underlying hardships. So we know that bias training doesn't adequately do this. So providing a way for sensitive information to be uncovered is essential. And traditionally, physicians only have around 10 minutes, right, to create rapport, build that trust, listen, do the screening, and it makes it even more difficult because a lot of birthing folks are reporting that they're feeling rushed and unheard throughout the process. So all of this is kind of piling up to really lead to how do we collect key information to make sure that resources are being allocated and needs are being met that birthing folks actually resonate with. A lot of times we are often pushing solutions that are not built for the people that they're meant to serve. So that voice and amplifying the voice is essential here, and being a source of listening and care is essential. So MyLua Health, we're a B2B SaaS company that creates value by combining AI and innovative approach to data collection to enhance transition of care and need identification. So we're looking to give birthing people access to timely support that represents their needs and how they would like to receive care in the system. We are going to launch officially in Q4 of this year, and we're looking to sell to health plans and providers to remove the burden of payment from the birthing person.
Javane, really quickly, your screen is half being shown, so the bottom half isn't being seen. Can you full screen? Perfect. Thank you.
Oh, that's sad. Okay, thank you. Thank you for that, Aish. I appreciate it. So we provide the earliest risk detection of maternal depression on the market. So we can predict the likelihood of birthing people experiencing depression during the postpartum period as early as the first trimester. And our technology is internationally patent pending because we know this is a global issue, but the US in particular is a big problem. We've validated 2 of our predictive models. The first model is at a system level, and essentially we can ingest EMR data, so electronic medical records and claims data to output a risk score. And we did this through our partnership with Trinity Health. And our second model is at the patient level, and it's where we administer risk assessments via surveys to birthing folks. And we did this through NIH. But a big issue here is that a lot of data is not represented in electronic health records. So we have to listen to stories. We have to understand what context is being left out and how cultural barriers, racial barriers might prohibit certain information from being extracted and understood as it pertains to care. And that leads me into something that's a bit more novel about us, and it's the collection of social risk factor data, but including the equitable components, racial, ethnic, and cultural components that really round out the lived experience and get us to understand what's happening on a day-to-day basis and how do we meet those needs. And lastly, our risk scores can be broken down into contributing factors. And based on those contributing factors, we're able to allocate resources at a localized level. So let's understand what lived experiences exist, what are the hardships, and then also, like I said before, it's really confirming that these hardships exist in the eyes of that birthing person, so the needs can be met. We have to listen. Listen, and instead of putting a band-aid solution, it's really understanding how to foster that trust and serve as a tool ultimately. So fostering trust takes longer than 10 minutes. So we're asking unique questions throughout the process, like what comes to mind when you hear the word strong or the word stress? As we know, in different cultures, the way that we engage with the environment is different. And currently the EPDS test or any kind of other anxiety and depression tests don't necessarily factor in cultural existence. So one culture might be less adverse to actually expressing emotions, and that needs to be factored in along the way because it becomes very difficult to detect anxiety and depression. And some people suffer in silence. So needing to factor in these cultural components is essential. So we've brought on experts onto our team that do just this. So we have an expert that specializes in how anxiety and depression presents in Black birthing folks and what questions need to be asked to solicit this high level of trust so we can meet those needs. And ultimately, we're looking to increase risk detection, engagement, satisfaction, and visit attendance. So we know that 40% of moms nationally don't attend a single postpartum care visit, and it's up to 70% in some marginalized communities. So it's important to get birthing folks in during this time, particularly as it pertains to the postpartum period, because 63% of the deaths are occurring during that time. And then to speak a little bit more about using data as advocacy, this is important. And as you look into, it's important and tricky. So there are studies that were conducted by the University of Virginia, and they surveyed medical students and asked whether they believed that Black people could feel pain, and then assessed the amount of medication they were administering based on their belief. So 222 participants were surveyed, and over 100 of them believed that Black people couldn't feel pain because their skin was either thicker or they had less nerve endings. And as you see in the graph, the stronger this belief is that Black people can't feel pain, the less they rated a Black person's pain overall. So this is leading to less than adequate pain medication as a result, which is huge here. And then also, as it pertains to communication and advocacy, we know that different cultures communicate differently, but there are studies that show that being marked as non-compliant or non-adherent or argumentative also in your like EHR, electronic health records, and your charts also leads to less than adequate pain medication. So when we think about advocacy, the reason why MyLua is really existing is being able to utilize the data that we're collecting, one being transparent to the birthing person, but also how do we utilize this data to advocate for our needs in a way that's powerful? It's clearly not enough to voice our concerns because there are so many misinterpretations or it being ignored. So we're acting as a tool to further amplify these stories and making sure that there's no dissonance in communication there. So we do have education around this. We utilize the data, the access to resources. We have a rubric by which we choose our partners as it pertains to cultural competency and congruency of care. So all of this is important as we think about amplifying the birthing experiences of each person we serve. Reduction in data silos. So often birthing folks are going to different facilities, and because of this, the data is disaggregated. So what we're doing is we created an API that has secure messaging, and we're able to push into the electronic medical records any kind of data that we're collecting to ensure that there aren't any silos, that when care is being administered, everything is being considered, and making sure that we're not contributing to this data silo problem. And then lastly, really driving impact through retention, like driving impact and retention through community. For so long, it hasn't come at the community level. So, and populations are difficult to connect with. So that's why we have lack of representation in studies. And there's also that trust barrier here. But in order to really de-bias our care, we have to drive it through the community and amplify the voices of the community as we go. And this will ultimately help inform clinical decision-making. So we're building out our community. It's very grassroots level, and we're looking to really start fostering this at scale. Like, how do we gain traction amongst our communities so we can really push for policy change is essential to what we do. So yeah, just a note on that and how we are, moving forward from a very grassroots level. This is our team. We all have lived experiences. My name is Santos, CEO and co-founder. We have Dr. Michael Conrad, he's our CTO. Julia Santos is my sister, and she's also our Chief Experience Officer, and she really molds out this journey, the experience every step of the way. Aishwarya Ravindran, and she's our Chief Operating Officer. And we're backed by a team. They have over 100 years of cumulative experience within healthcare. They're super empathetic and understand how data needs to be treated. How do we de-bias? How do we cut the data to ensure that people are being represented and are not further perpetuating the problem as it pertains to bias in data? So this is essential here. And then we have an advisory team. Our advisory team is incredible. So just making sure that we're surrounding ourselves with subject matter experts in the field that can really push us to go deep and build equitably. And that is all. So if you have any questions, feel free to reach out to me. The QR code will bring you to my LinkedIn. I also have my email on the side if you have any questions. Thank you.
Excellent. Thank you so much, David. I really appreciated the care and attention that is being paid to ensuring that you do de-bias the way in which data is collected and distributed and disseminated. If anyone has any questions for Dr. Harris or for Ms. Santos, please feel free to put them in the chat. We are going to move next to Kimberly Seals-Allers of the IRTH app and Narrative Nation. Kimberly, you can share your screen and get started.
Great. Can everyone see my screen? Okay, great. Thank you so much. Really excited. Those were such powerful presentations. My name is Kimberly Sales-Allers. I'm here to share with you the way that we're using consumer-facing technology and digital platforms to address bias and racism in care, but also using community-centered approaches. I really just wanted to start my presentation by saying, everything that Dr. Davis said, really wanted to lift up some of the amazing Black researchers who are leading the way for us to decolonize data, to rethink what data looks like, how it feels, who designs it, who it's for, how it's disseminated, including Dr. Harris, Dr. Karen Scott, Dr. Monica McLemore, Dr. Ifeanyi Asiodu, Dr. Joya Kriya-Perry, so many Black researchers who are leading this conversation. So if you are not tapped in to this movement and this research, I would definitely encourage you to do that and want to just +1 everything that Dr. Harris said to you today. So I'll center in on a few key points that we really use. Again, not wanting to repeat some of the amazing points I've already made, but asking the question, data for whom, right? We know that data has often actually been made for other researchers, not for the communities that are actually impacted by the data, and how the needs need to be designed by the community. Dr. Harris touched on the need for an assets-based approach, not a deficit-based approach, transparency being critical, and we'll talk about what that means. And for us, accountability-driven, right? What is the data for what, right? Is it data just for data's sake? Is it data just for us to know things that we probably already know, or what? And so really wanting to center these ideas as critical to how we think about our processes at Narrative Nation and the IRTH. And so we've been focused on addressing the problem of racism and bias in maternity care. And so much of what I'll be talking about is really centering this approach to the problem that we seek to solve around this issue. So just to give you a level set, we know that Black and brown folks are not responding to HCAHPS and other hospital administered surveys in the same, at a high rate, whether they're press games, anything like that. We can talk about why. When we look at what is happening now around addressing racism and bias, anti-bias trainings, an important first step, there actually is no data that they actually work. And no one ever checks back in to see if they've improved the lived experience of care for Black and brown folks. So we have a system with no accountability and actually no data to support it, even though this is continued to be put out as the way to fix the problem. Unfortunately, it's become a tick the box exercise at far too many places. Next, we've been using evidence-based research, but for years in my work, I've been asking evidence-based on whom, because we have to acknowledge that much of the evidence-based research and maternity care that is being used did not disproportionately include women of color and Black women. And now Black women are disproportionately dying, often under the same evidence maternity care, but that evidence didn't include them. So how do we actually create a new evidence base that actually over-indexes Black women and other women of color, those who are currently being disproportionately harmed by the system? Right? And then understanding that maternal mortality review boards have been great sources of data. However, we should not be trying to solve this problem from the grave. It's deeply troubling to me personally that a Black woman has to die before people begin to look at bias on their teams, gaps in their care. And with the IRTH app, we say, let's learn from the living. We can capture enough lived experience data to actually prevent deaths. And so that is the way that we look at our approaches. So we created IRTH, which is like the word birth, but we dropped the B for bias. So it's spelled IRTH, as the first of its kind nonprofit review and recommendation platform that aggregates data on the front end and back end, where users can leave reviews of their OBGYNs, birthing hospitals, and pediatricians. We really want to capture that whole perinatal spectrum. Our users can also search reviews by hospital, doctor, and username. Again, this idea of transparency of information being critical to our process. On the back end, we turn these reviews into quantitative and qualitative data to work directly with hospitals, payers, and providers. What are the blind spots? What are the gaps? How can we learn from the living to provide more respectful and equitable care and ultimately save lives, right? And then as a consumer-facing tool, we are here for transparency as critical for birth equity and accountability. right? Within health systems, there's lots of data on what's going on with Black women and the maternal mortality, morbidity crisis, but very little accountability for action and outcomes. So we drive that by using publicly shared ratings and reviews as a consumer tool to push for systemic change. And so just to be clear, we have a structured review process. I'm going to share a little bit about the background of this work. And it is not just a free-form commenting space. We ask questions designed to generate information and designed to help us on the back end identify frequency and patterns, and then develop the strategic action plans to help hospitals improve. We accept reviews not just from the mother or the birthing person, but we also accept reviews from fathers. We accept reviews from doulas and hospital-based midwives, again, with a strong belief that the new evidence base needs to include all, and that doulas are our eyes and ears for birth. They are our neighborhood watch, and they see a number of births. And so we really need to be centering their lived experience as well. There's lots of talk about the value of doulas at the bedside and at the birth, but their lived experience is important data that needs to be captured. I mentioned our review types and how folks can search, and then we're excited to have our Spanish language launching in the next 30 days. And so again, on the front end, we are a dual market product, right? We believe data works both ways. On the front end, we're giving our community crowdsourced peer reviews so that they can lean into their community as a source for provider selection. We believe that technology can address some of the power imbalances. Dr. Harris spoke deeply about the ways that whose data is valued and whose is not has been kind of perpetuated throughout the system. If you look at it historically on that hierarchy of data that is valued, you can look at the turn of the century, this was literally made up. It was literally made up by a group of elite, mostly white male academics who literally made it up. It's a construct, right? And so we can deconstruct that and create something new. And I believe technology has a unique power to address some of those imbalances. And then we're shifting our focus on those most burdened by the system. You know, I get asked many times, what about hospitals? What will the hospitals think? We're really centered on the community and lifting up them and centering their needs first, and then letting the hospital benefit and improve from that knowledge. But we're really centering the community in our process. And then in our back-end work, we turn those qualitative experiences into actionable data. Our head of systems change, Sheridan Blackwell, leads our processes around helping hospitals learn from the living, developing an improvement plan, implementing that plan, et cetera. I'll walk through a little bit more about that. And then how can we use IRTH as an early warning detection system, right? Again, not waiting for something bad to happen, but understanding frequencies and patterns that we all know are more likely to lead to harm, identifying that, and then moving forward from there. And then IRTH provides hyperlocal data. I tell everyone that racism in New York City is not like racism in Birmingham, Alabama, which is not like racism in Newark, which is not like racism in Southern New Jersey. And so we really need a hyperlocal approach so we can understand that specific community and then develop solutions from there. So that's the way we approach it. I want to pause here to share a little bit about how we got to this approach. I am a journalist by trade. I am not an academic or a researcher. I come to this work really with a different approach to how we capture information. As a journalist, a former writer at Fortune magazine, I covered Wall Street for many years for the New York Post. I went to London where Rupert Murdoch put me to work at his newspapers where I covered business. And in all of that work, I'm also the author of 5 books. The research comes from people. And so after I had my own traumatic birth experience and was activated to think about how I could use my passion for storytelling and my news gathering techniques in service of this issue, I learned the ways that people thought answers were in the community, were in academic research and in medical experts, and those are great. But I was saying, what about the community, right? Because my work around information gathering was always about going to the community first, knocking on doors. So now I am the executive director of Narrative Nation. It is the only Black woman-led technology nonprofit. We create narrative-centered tech products and digital platforms simply to address racial disparities in maternal and infant health. Our 2 signature projects, the IRTH app, which we're talking about today, and our grant-funded Birthright podcast, where we only tell joyful Black birthing stories. Really want to amplify what Dr. Harris said about the need for joy in birth equity. I created Birthright really to address the doom and gloom narrative that's way too common in Black maternal health coverage and often in Black maternal health research. I'm excited to share that we actually analyzed our podcasts for the past 2 seasons and have created an instructional tool for healthcare professionals. And I'll share a little bit about that, but we can learn from joy, and that's really important. And I encourage you to tap in to the positive Black birthing stories because they too have data, right? They too have learnings, and we need to capture that. And so that work that I started was around this framework. Whatever the question, the answers in the community, right? Not necessarily medical experts, academic research journals, et cetera, but what was the community's answer? So this work I'm going to share briefly about as really the foreground to what we do at IRTH and what I bring to it was started and funded by the Kellogg Foundation. We started this work in Birmingham, Jackson, New Orleans. We got an additional $500,000 grant. I took it to Detroit and Philadelphia, really around this model. And the model was, let me ask the community for answers. As I look for folks who were trying to figure out what was going on with birth and breastfeeding answers, questions, we decided to launch in the community. And so we started knocking on doors with my team, asking mothers, parents, fathers, uncles, aunties, questions around what they thought could be solutions to the problem. Not could they help us execute our solution, but what did they think were the active solutions to some of the challenges in birth and breastfeeding in our community? In addition to that, we learned that one of the most important things that we can do when we're gathering data or however we're defining it is the ways that we ask questions, right? It is an art and a science, and it needs to be understood from a community-centered perspective. So how we ask questions in this project, how we ask questions in the IRTH app is a very important part of the process of how we think differently and actually gather more important data. The X part is about who is asking matters. Who is asking the questions matters. We know that hospitals and medical systems have an earned distrust from communities of color that is well documented and well publicized. If you don't know the history of the Tuskegee experiment, Henrietta Lacks, all the different ways. Dr. Harris mentioned the original enslaved women who were used to really build the OBGYN field. All of this and many more has contributed to the earned distrust. And so who's asking the question really matters. And who are the trusted messengers so that we can receive the optimal answers. Because what we have found is that many hospital administered surveys, even those great ones and those that are talking about racism and bias and many of the ways that we're trying to dig at this, still are not getting the response rates because the hospitals simply don't have the trust of communities of color, right? Which is why we have put our tool in their hands and we use a community-centered approach to address it. We take community engagement very seriously. This is our team in Detroit that helped us knock on doors to help ask the questions in the community around solutions. In this, we have local residents, we have MPH students from the University of Michigan who were able to come and join us in our work. But this is the heart of what I've been doing for 8 years when I decided to move this process to a digital platform. So we went door to door in the neighborhood, among other ways, to really meet people where they're at, right? Again, thinking about digital platforms, meeting people where they're at in their mobile devices, and literally not asking people to come to us in our focus group, but going to them, sitting with them on their stoop, playing with them with their children, going to them to ask questions around their ideas on solutions, right? Completely community generated. And so we model this today with our IRTH program, where we work very closely with birth workers and other doulas and other birth workers who serve across the country as our IRTH ambassadors, right? Because we know that they are trusted resources in our community. And so we have created a unique approach to how we engage with community that centers around doulas and birth workers. We create a wraparound support program for them. So we have IRTH ambassadors who are working with us. They help us capture reviews from the community. They represent IRTH at community events. We ask them to leave reviews of their own births that they attend. They are out being our eyes and ears, talking to families, being a resource. But in return, what we did was listen to doulas first and birth workers first. And we created a wraparound support program. We piloted this in New York City with the support of the New York State Health Foundation. The first thing we gave the doulas in our IRTH ambassador cohort, 22 doulas in New York City, we gave them a therapist, a mental health therapist who was available to them for bi-weekly sessions and individual sessions. We gave them a monthly stipend to help supplement what they're earning. We gave them a professional development series and a speaker series around their needs, helping them build their business, helping them understand their brands. Again, putting in the extra work for equity to understand how we can get the most richest and detailed information. Too many times folks just want to send out something, ask other Black people you know to send out something, and don't want to put in the work around meaningful community engagement. And this is our approach to how we engage in community all the time, including our IRTH ambassador program. And then we create community with the birth workers. So we think of it as an intervention within an intervention, because quite frankly, we can't sustain doulas if we're not building into pouring into them as people. Very much related to what we have been saying on social media. Everyone is talking about doulas, but nobody is talking about the actual doulas, right? And so we actually care about them as people, pouring into them and making sure that their workforce is sustained, right? And then thinking about our connection with them as a critical way that we build that trust and work with communities. And so in our data that we actually glean from this deep dive process, we often say you can't change what you can't see. So one of the things I think IRTH does well, we really try to get into the details, because I think we're talking about bias in a very abstract way. What is it? What does that really mean? The provider does the training, they think they're nailing it. The patient is having a completely different experience. How do we marry the two? So we ask very detailed questions, right? And so we can get to the heart of it. And then on the back end, we can identify frequencies and patterns, not one-offs, but frequencies and patterns. So we can go to a provider and say, hey, we have 500 reviews. This many people said they were yelled at. This many people said that physical privacy was violated. This is when this happened. This is people whose names have been mentioned in frequency. We really get into the details, right? We call this, the young people call this receipts data, meaning we bring the receipts because we want to show what happened and how it happened. This is the way that we're rethinking the information that is needed to actually push for change. So right now, we're proud to top 10,000 reviews in our national database, representing 47 states. The number one negative experience being reported in IRTH right now is my request for help were ignored or refused. Number one. Number two, my pain levels were dismissed. Deeply concerning when we know that in pretty much every Black maternal death story, someone's pain levels were dismissed. Number three, I was scolded, yelled at, or threatened. Deeply concerning, physical privacy violated, assumptions based on racial stereotypes. Too many people feeling like because they're Black, people walk in the room, the first thing they're asking is if they're on WIC. Not that there's anything wrong with that, but why is that the first question that you're asking me when you meet me? Too many people feel like they're being coerced into contraception while they're in active labor. Too many rude comments based on judgments about our family size, our children's spacing, whether we're married or not, is too much. It's too much. And these are the judgments that impact care. Right? That is the way that happens. These are judgments that allow people to assign value, and then that impacts the quality of care that you receive. And so we're documenting, we're notating. Our reviews are moderated by a volunteer panel, and then they are released into our database. We are here for transparency. And we want to redefine what is a 5-star experience for Black birthing people. I ask hospitals that all the time. What is a 5-star experience for Black birthing people? And no one can be able to tell me just yet. We believe in defining that and making that our standard, and not simply the standard of mortality or morbidity, because just because you didn't kill us or nearly kill us, it doesn't mean that you did a good job. Right? That is not the goal. And so we look at the ways that we learn, whether we're learning about what makes a patient feel safe in a hospital. We learn so much around pain levels. We learn a lot about residents and pediatricians and the ways that training can be improved in hospitals. But we do it from an independent community-centered source, because so many times when we're in community, people feel that if they respond to a hospital administered survey, they don't know where it's going. They don't know if there's going to be retribution or any kind of feedback. They have to take their baby back to that same hospital or within that health system for future care, and they are afraid to be honest about their experiences. And so we see IRTH as a complement, a tool. I am excited about the ways that we're looking at traditional data and redefining that, using digital platforms, leveraging technology, because we need all the things, right? And how can what we're learning on a deeply qualitative basis be learnings that can complement all the other great things going on? In our hospital pilots, we work directly with a hospital to do a review collection campaign. We analyze those reviews. We develop an action plan, an improvement plan. We implement that plan, and then we go back in and do another review collection as a test of change. Always about data and community accountability being interconnected. Right now, we're proud that our data is impacting over 100 hospitals nationwide, including our pilots in Detroit, Philadelphia, and a 3-year pilot we're about to launch with 2 hospitals in LA, one in Sacramento, the Alameda Public Health Department and San Francisco Public Health Department in the Bay Area, and also our work with quality improvement collaboratives here in New York City, 32 hospitals in the state of Louisiana. We're excited and hopeful around expanding our work in the New Jersey area as well. And so our vision is that we become the good housekeeping seal of approval for Black and brown birthing people, that we will drive desire and demand, right? Being critical to how we do that, consumers will desire for their providers and hospitals to be IRTH approved. Hospitals and providers will look at the lived experience and listening to it and learning from it as the most important accreditation they can possibly achieve. At the end of our pilots, we do acknowledge and award our hospital partners because we want them to feel good that they've listened to their community, they've analyzed and identified patterns and bias through our qualitative data, and that they did something about it. And so understanding that transparency is really important when we think about why hospitals are failing to get the response rates on many different efforts around patient experience, around QI. We often let them know that transparency is the fastest way to community trust. In any relationship where trust is broken, you're going to need transparency, I promise you, to repair it, right? And so how can transparency with the community, transparency of information be critical to how we rethink data as critical to trust? And so our new evidence base for equity is about community facing, community first. Our data belongs to the community first. That is a non-negotiable in our work. Our data is reviewed and our reviews are immediately transparent and of use to the community, right? It is given to them in a form that they can relatively use. Right now, our response time for approving reviews is about 7 to 10 business days, depending on how our volunteers are doing. But this is incredibly important. There will not be equity without accountability and transparency. And that includes accountability in our data approaches and our data systems, and then data for all, accessible, understandable, publicly shared. At the end of our processes, not only do we create accessible data in terms of infographics, social media, but we do media outreach. We will be producing for New York City our IRTH approved best places for Black people to birth, according to IRTH reviews, lists that will be publicly disseminated, right? This is the way that we feel a completely consumer-focused approach to sharing our information and putting it out there. So I'm excited about that and intersecting. Ooh, I didn't need to do that. I forgot one had music on it. I wanted to share that our birthright, learning from the lived experience, listening experience for doctors and healthcare professionals will be launching for Black Maternal Health Week. As I shared, we had these amazing researchers come on, analyze 23 transcripts from birthright, 55 guests. What can we learn from listening to Joy? So I hope that you all will stay in touch to experience these lessons from Black birthing joy that we think are critical points in the data spectrum that need to be added to the whole piece of work that's happening right now. And then I look forward to staying in touch. Sheridan Blackwell, who heads our hospitals and partnerships, our systems change work. You can get in touch with us, and I look forward to answering questions. Thank you so much for your time.
Thank you so much, Kimberly. Really appreciate it. You know, and every time I listen to the presentation, I hear and learn something new, and always appreciate the work that all of you are doing, and the way that you are noticing the systemic changes from the research, and then putting that into action in the work that you are developing. I really think that this is critical to really being able to change the landscape. We've had a couple of questions in the chat, and if anyone has any questions, please feel free. A lot of great comments, of course, applauding the work that you all are doing. And we do have a couple of questions, so I will read the questions, and then whomever it is for, whoever can answer, wants to answer, can do so. So the first question is, as with baby-friendly hospitals, how does a hospital keep the IRTH approval updated over time?
Great question. So we are in the early stages of this process. What we are envisioning, one thing that's included in our pilot is a 6-month check-in that we produce another data report. And so there will be ongoing access to our data, an ongoing accountability mechanism to see what types of negative and positive practice behaviors have improved, gone down, et cetera, et cetera. So that is something that we will expect hospitals to do, and we will be checking that data and providing that to them and creating the accountability mechanisms throughout that process. And I see the next question, Cecile, if you want me to grab it, that one's for me. Actually, at this time, birth centers are well, definitely not home births. So birth centers can be reviewed. I want to just offer that IRTH's primary focus is where the majority of deaths are happening, which is within hospitals. So we are really focused on the medical industrial complex and that systems change work. You can technically review a birth center in the IRTH app. There are a number of amazing birth center reviews in the IRTH app. We have not added home births yet, but that is certainly possible. Our data research and our advocacy work and our targeted outreach is very much focused on hospital and health systems at this time. But please leave a birth center review.
And I just wanted to back up a little bit and just make sure that everyone knows what baby-friendly hospital is. So if anyone wants to explain that has an understanding of that, please feel free to do that, just so we're all on the same page.
I can jump in. I thought Dr. Harris might want to do this one, but baby-friendly is a designation that is related to how people can access.
I can answer that.
Okay, there we go.
Sorry, it looks like I'm experiencing a delay. It's just a designation that hospitals can apply for that basically says that they're doing work to support the choice of families who want to breastfeed or chest feed. I forces the entire patient population to breastfeed because that is what people interpret it to mean. And some people who implement it also interpret it to be that. But it really is designed to support those who have chosen to provide human milk to their babies in that choice. And it basically says you have good practices in place and you're following a set of 10 steps consistently. And I will also just, amplify or highlight that baby-friendly also has been shown not to protect Black women, although these policies are in place. It still is not bias and racism free. And so we still, even in communities of color who are baby-friendly designated, still have very high rates of formula use and supplementation despite having that designation.
Yes, and I will just add to that, we have a lot of IRTH app reviews supporting exactly what Dr. Harris says. Too many Black and brown folks in baby-friendly hospitals, not sure why their babies were given formula, wanting to breastfeed. Some people have detailed comments about the levels of their own colostrum, but it's not being administered the same way. And we know that people are not being treated the same way, even the same place. So sometimes these designations are helpful, but certainly not being applied to all. It's a big issue.
Thank you for sharing that and that nuance. See, this is why having an understanding of the data in nuanced ways is very critical, because you can read and interpret in a particular way, but there's really a lot in the background that you need to understand. So there's another question. I'm curious to know how the hospitals have received the information data of community experiences. Were they receptive to hear what the community was reporting and open to change some of their practices?
Yes, I mean, any hospital that agrees to work with us, they have signed an MOU that explains like that is what they have signed on to do, that they will change, they will implement, we will do the improvement, we will do the test of change, and those reviews will be public, right? And so again, yes, the hospitals have done the work so far to make the improvements, you know, different levels, and they are receptive. But the receptiveness, quite frankly, comes from the fact that our reviews are transparent and they want their public perception to improve. And so the transparency drives the action because our reviews are transparent, because without the transparency, who's going to hold them accountable? So yes, they are receptive. They are very much open to change because they want their public facing reviews to improve. And that is really one of our key drivers. If not, then we would just be asking them nicely. And we've tried that for many years.
Excellent. Any other questions or comments or points of clarification? We do have a couple minutes left for anything anyone wants to ask. And you may be able to just raise your hand or come off the mic to open your mic to ask the questions as well. I have a question. So in your conversation, Kim, you said that you go to the families to receive reviews. Can you share more about that process? I feel like this is a critical piece of a process, and Nastassia, you perhaps have a similar conversation that you can have around, you know, being able to go to families and collect data from them, and some things that you have learned and experienced, and JVA same from that process, because that really takes a lot of trust, and I would assume some level of training or previous connection to the community. I'm not sure, but I'm very curious about that.
Dr. Harris, you want to go? Is she having a lag? I could start. I think she might be having a tech issue. Oh, there we go.
Sorry, I am on 2 devices because my Zoom keeps kicking me out. So if you're hearing an echo, it's probably me. I would say what I think I've learned for the most in doing community-based research is not what you would think as far as the information, but more how people try to disparage that collection of that information, I think was eye-opening for me. I had actually reached out to Dr. Asiadu as I was doing this landscape study to do our surveying, and a lot of it was Qualtrics survey. They would do their consent and then they would get access to the survey. And she said, don't do it that way. Because we found that we were getting erroneous survey information, people who were just filling out whatever because it said for Black people, and they would just write whatever on it. And so when we started doing our data collection, we saw the same thing. Depending on who shared our post, there were people who were just putting in fake phone numbers, fake names, writing racist comments into the Google Doc. It was just all kinds of crazy stuff that was happening. So I know that's not quite what you were asking, but I do find that when things are targeted specifically towards the Black community, people don't seem to like that very much and try to tamper with it for whatever reason. And so that conversation with her kind of helped me to safeguard our data, because they actually couldn't get to our survey. We pre-screened them first, we validated that they were a real person, and then from there we were able to give them access to our survey. And that wasn't a process that I expected to have to encounter, but unfortunately that's what we're dealing with in collecting some research.
I'll just add to that, and apologies, looks like Sharon and I must have come in on the wrong login. So sorry that I have the wrong name up. So I just one co-sign to that. When we first launched Earth, well, we spent 18 months in pilot before we wrote one line of code. We were grant funded to actually do feedback surveys, community engagement in 5 cities. But during that time of building, we were constantly being attacked. And we had to like pause. The Ford Foundation has amazing people who are focused on building technology for Black and Brown people, but doing it safely. We spent a lot of time with them to understand how to make our digital platform safe. We have a lot of safety protocols within Earth. This is a big issue. And so I don't want to, it can't be overstated that when you're actually building tools for Black and Brown people, you will be attacked. We were attacked. Everything that we were doing was attacked. It was really disgusting. So it takes an extra level of work. And so when we talk about the thoughtfulness that needs to go into data collection in our communities, there's also that safety feature. I want to say to the bigger question, one of the things that I love about my work, particularly in Detroit, where I spent a lot of time working on the ground, was the ways that the community was so clear. I said to the Kellogg Foundation, I wish I could have captured the amount of time it took when we used to say to people, hey, we're here, we talk about the problem. What do you think the solution should be? Like, people were blown because we weren't coming to them saying, hey, we think we should do this, will you help us? We actually were going to them for the solution. We talked to fathers. I love talking to Black men, and we don't talk to them enough. One of the stories I just want to quickly share, I wish I was going to share this slide, but when we got to the city, there was a story being told that Black men would not come to a breastfeeding support group. Dr. Harris definitely spoke about the ways that our language support, is that culturally appropriate, et cetera, et cetera. So we actually went to fathers, started asking them how they identify themselves, right? Many times our research questions are based on how we see people, often not a strengths-based approach. We went to fathers, the words that they said about themselves, oh my God, strong, present, all these things. Right now, again, I don't have any judgment in that. If that's how you see yourself, that's the way I need to speak to you. So we got there, we listened to fathers, learned how they identified themselves. Then we created the Great Dads Meetup, and everybody came, right? Again, if you're framing things in your language, then it's not going to get you the results. You have to understand the communities that you're in, how they see themselves, what values are important to them as the first step of doing that work. So I just want to offer that the work that, we're talking about and the ways that Dr. Harris leads it is very nuanced. It is not, we just need a new survey and we're going to, put Black people on the front page. It is about understanding these nuances and details and capturing everybody in the experience. One of my favorite learnings.
That is very powerful and helpful to hear. JBNA, I think you have your microphone open.
Yeah, I was just going to amplify that. I feel like it's not hard to get information. I feel like every birthing person we go to wants to tell their story. It's whether you're going to make the time and capacity to actually listen and hear what's being said and not change it or anchor it based on your bias or your expectations or what you're coming into. So when Kimberly's kind of like saying like leave everything out the door, like it's really about that person, and any kind of preconceived notions just need to be left there. So I think that's what we've realized throughout the process, is that we need to make time to listen and make people feel heard in a way, and making sure that we're not morphing what is being said. So no anchoring there, but yeah, just amplifying both Dr. Harris and Kimberly's experience.
Mm-hmm. I actually wanted to ask you a follow-up question, JBNA, about you stated that depression and anxiety present differently in Black and Brown folk, and that your team works to ask questions that are, capture that. So if you could share, an example of then the questions that would be asked to capture that, I think that might be useful.
Yeah. I think on one of the slides I had, like, when you hear the word strong, what does that mean to you, or what comes to mind? A lot of times there's the superwoman complex where it's like you really have to present as like carrying your family, and that stops us from being vulnerable. So understanding if like vulnerability is something that comes out of being strong, right? The way that we kind of push everyone else's needs ahead of our own and carry this level of burden puts an excessive amount of stress on us. So the way that we look at answers like that and factor that into our algorithm, and understanding that, hey, when you are presenting as in seeing this as such a good thing, which it is good, but it has its only in moderation. So yeah, we're asking like just unique questions similar to that. And we're still building out our database and working with, like I mentioned, our expert who does this to understand what other questions need to be asked. What are we missing? And it's through our interviews as well that we're starting to uncover like, oh, okay, this would just traditionally be problematic, but we're seeing it in a different light. And like our ability to survive is our biggest strength, but also our biggest weakness, because we begin to desensitize ourselves from what would traditionally be considered like not like toxic, but just kind of like a survival mechanism. So we have to see what is survival and what is now not working for you and is now working against you. So that's just one example.
Yeah, literally was in a conversation yesterday and I got a new perspective on the usage of the word resilient and how that's used sometimes to have people bear an extra burden that they may or may not want to bear, right? So definitely appreciate that, ability to deconstruct those words and utilize that to understand. So we have 2 minutes left for our session today. Does anyone have any final questions or comments for our presenters they would like to share? Excellent. So thank you all so much for sharing this. This was extremely valuable to the community, to people who are, going to be looking at your work and perhaps creating something else or supporting your work. And, I really can't overstate how wonderful this has been for you to participate and to share your work. Thank you so much. And we will absolutely be in touch. And thank you everyone for joining this conversation. And I hope that everyone is able to connect with everyone here, anyone here that they find to be someone who they need in their community or want or to be a support to, etc. I will be sharing out the recording to everyone who has registered, as well as any resources attached to the presentation, such as the conference that Dr. Harris has coming up. So the link to the conference. So it's a pleasure to have you all here, and thank you so much, and have a wonderful weekend. Take care.
Thank you. Bye.